Good evening, everyone. I hope I'm audible and visible to you all. Yes, you guys can just let me know in the comment section. Am I visible to everyone? Yes. Good evening. Good evening. Okay, guys. Good. Let's begin. So today in this session, we are going to talk about. Today in this session, we are going to talk about some important topics in the PSM. For example, the first topic that we are going to discuss is sexually transmitted diseases, followed by the level of preventions and the family planning and contraception. Okay, so I'll make sure that guys we can reach out all the important topics step by step, and I'll make sure that we'll solve all the possible questions that have been asked repeatedly in the exams. Okay, so let's begin with the first chapter, guys, sexually transmitted diseases. If I talk about the program that was initiated, guys, to control the prevention of the AIDS, there was a program that was launched so that it was aimed that every person in India should be free from AIDS. Every person in India should be free from AIDS or HIV. And such program is called as National AIDS Control Program. National AIDS Control Program. So as we all know that the most common route of transmission of sexually transmitted disease is sexual, right? AIDS most common route of transmission is sexual. So the government has launched some services to control these infections, and such type of service that we are going to learn about, the first one, that is called Suraksha Clinic. The first one that we are going to talk about is Suraksha Clinic. Now, what are the services for this Suraksha Clinic, my dear students? Remember that they give services for sexually transmitted infections, for sexually transmitted infections, for sexually transmitted infections or reproductive tract infections, or reproductive tract infections. Now, if you can recall a bit from your last session that we had, guys, in the last session I've discussed that the aim of the Suraksha Clinic was to give the people a symptomatic treatment. Okay, what do I mean by the symptomatic treatment? Let me explain it for you guys. So I am talking about, now the patient is coming to you with the complaining of the vaginal discharge. Okay, now you have a patient with the complaints of vaginal discharge. Now based upon your knowledge, you know that we have a different types of discharge when a patient is complaining of vaginal discharge. What are the different types of discharge we have, my dear students? We can have a curdy discharge, we can have a greenish discharge, we can have a creamy discharge, we can have a frothy discharge. Okay, so based upon these discharge, we can particularly diagnose a particular condition. For example, if the patient is coming with a curdy discharge, you can diagnose it with as a candidiasis. Okay, patient is coming with a greenish discharge, you can go with the trichomoniasis. Patient is coming with a creamy or frothy discharge, you can go with the bacterial vaginosis. But the service that was Suraksha Clinic providing, any patient coming to you with the complaining of a particular discharge, you have to directly prescribe a kit. What exactly is this kit? I will tell you shortly. Okay, so this Suraksha Clinic, so remember guys, this Suraksha Clinic, guys, it was a syndromic approach of management. It was a syndromic approach of management. What do I mean by syndromic approach of management, guys? It means that based on symptoms, treatment is based on symptoms. It means, guys, treatment is based on symptoms and not on the diagnosis. It means treatment is based on symptoms and not on diagnosis. Is that clear? So what is a Suraksha Clinic, guys? It's a syndromic approach of management. It's a syndromic approach of management. If in case they can ask you the image based question, guys, they can give you this logo, guys. Remember, guys, this logo is for Suraksha Clinic and it gives sexual and reproductive health services. It gives sexual and reproductive health services. Is that clear, guys? So based upon the symptoms, we have different kits based upon symptoms. Now any patient complaining of a particular symptom, guys, we have different kits, and these kits contain a particular medication that will treat the particular condition. Okay, so let's discuss kit number 1, which is gray color. Okay guys, the first kit that we are going to study about is kit 1 gray. So as per this kit, guys, any patient which will complain of, any patient who will complaining of urethral discharge, any patient complains of urethral discharge or anorectal discharge or anorectal discharge, what you will prescribe, guys? Which kit you will prescribe? Kit 1 gray. Which kit you will prescribe? Kit 1 gray. So after, in the second slide, I will teach you guys what are the medications inside the each kit. Okay, so kit 1 gray, kit 1 gray, any patient complaining of urethral discharge or anorectal discharge. Followed by that, guys, we have a kit 2 green. Followed by that, we have a kit number 2, which is green color, and in this green color kit, guys, any patient complaining of the vaginal discharge, any patient complaining of the vaginal discharge, you will prescribe which kit? Any patient with a complaining of vaginal discharge, you will prescribe green kit. Okay, so the first one was kit 1 gray, urethral discharge or anorectal discharge. Kit 2 green, second one vaginal discharge. Okay, then guys, third one will be the white, kit 3. Kit 3, third one will be the white, kit 3. Now you will remember, guys, kit 3, kit 4 and kit 5. All these three kits, guys, they are for the genital ulcers. Write it down, guys. They are for genital ulcers. They are for genital ulcers. Now depends upon the whether the genital ulcer is herpetic or they are non-herpetic. If I talk about genital ulcers, first one, white color, guys, they have non-herpetic genital ulcers. Non-herpetic genital ulcers which will respond to penicillin. They will respond to penicillin. Okay, so any patient coming with the non-herpetic ulcers, okay, you will prescribe kit white, that is 3. Okay, but they will respond to penicillin. Again, guys, if I talk about kit 4, that is blue, again blue will be non-herpetic, but patients who are allergic to penicillin. But the patients who are allergic to penicillin. The patients who are allergic to penicillin, guys, we will prescribe which kit? Kit 4, that is blue color. And then, guys, the kit 5, which is red color, genital ulcers having herpetic. Genital ulcers herpetic, and they will respond to acyclovir. And they will respond to acyclovir. Again, from the beginning, guys, any patient coming to you with a complaining of the urethral discharge or the anorectal discharge, the kit that will prescribe at that time is the kit gray. Any patient coming to you with a complaining of vaginal discharge, you will prescribe kit 2 green. Okay, genital ulcers, patient who will respond to penicillin, you will prescribe white. Patient genital ulcers non-herpetic, which is allergic to penicillin, you will prescribe the blue color. And patient having the herpetic genital ulcers, you will prescribe which color kit? You will prescribe a red color kit. Okay, then the sixth one, guys, we have a kit number 6 called as yellow kit. We have a kit number 6. We have a kit number 6 called as yellow kit. So any patient complaining of lower abdominal pain, any patient who complains of lower abdominal pain, you will prescribe which kit, guys? Kit 6, that is yellow color. And which conditions mainly, if I talk about in a which conditions mainly we have a lower abdominal pain infections when the patient is complaining of PID, pelvic inflammatory disease. Pelvic inflammatory disease. So let me tell you a bit about this pelvic inflammatory disease, guys. You all know most common cause is chlamydia. Most common cause is chlamydia. Let's integrate a little bit PID, guys. The most common cause is chlamydia, and you already know, guys, this chlamydia or this PID is also the most common cause for the ectopic pregnancy. Okay, guys, most common cause of ectopic pregnancy is infections only. And which infections? PID. Okay, and if you remember the triad, what is the triad of PID, guys? What is the triad of PID? Let's remember, guys. It's uterine tenderness, it's uterine tenderness, it's cervical motion tenderness, cervical motion tenderness, and adnexal tenderness. And adnexal tenderness. So, guys, what is the triad of PID, guys? Uterine tenderness, cervical motion tenderness, and adnexal tenderness. And remember, guys, any patient who will complaining of the lower abdominal pain, as per the Suraksha Clinic, which kit you will prescribe, guys? Yellow color kit. Which kit you will prescribe, guys? Yellow color kit. And the last one is the black color, guys. Remember the kit 7. The kit 7 is black color. Remember, it is patient, inguinal bubo, which means, guys, patient complaining having inflamed lymph nodes. Patient with inflamed lymph nodes, what do you will prescribe, guys? You will prescribe the kit 7, that is black color. You will prescribe kit 7, which is black color. So that was all about the color kits. Okay, so let's have a quick review, guys. Let's have a quick review that what we have studied, guys. So first of all, I discussed about a national AIDS control program. It was launched in India so that every person in India should be free from HIV or AIDS. Okay, then the Suraksha Clinic gives us the services for reproductive or genital tract infections. But the Suraksha Clinic has a syndromic approach. What do I mean by syndromic approach, guys? By syndromic approach, I mean that the patient will be treated as per the symptoms, not as per the diagnosis. Then I made you clear with the example of a vaginal discharge, that if the patient is complaining of the vaginal discharge, whether it is a curdy, whether it's frothy, creamy, greenish, whatever the color is, whatever the diagnosis is, just a patient coming with the discharge, you are prescribed a particular kit and not on basis of diagnosis. Is that clear? So first one was kit 1 gray, urethral discharge or anorectal discharge. Second one was kit 2 green, vaginal discharge. Kit 3 for genital ulcers, non-herpetic, which are responding to penicillin. Kit number 4, guys, blue color, non-herpetic, which are allergic to penicillin. Kit number 5, red color, herpetic genital ulcers. Kit 6, yellow color, lower abdominal pain. Kit 7, black color, inflamed lymph nodes. Now, how the examiner will ask the question, guys, based upon this particular topic, let me show you guys how an examiner can ask you guys a question. Okay, so see, guys, a 38-year-old male presented to the Suraksha Clinic with anorectal discharge. He will complaining of anorectal discharge. Which of the following color coded kits? Which of the following color coded kits is recommended for the syndromic management of sexually transmitted diseases? So you already know, guys, if the patient is complaining of urethral or anorectal discharge, if the patient is complaining of anorectal discharge, which kit you will prescribe, guys? Kit 1, that is gray color. Kit 1, that is gray color. Okay, kit 1 is gray. If I talk about green color, guys, green was for the vaginal discharge. Okay, green was for the vaginal discharge. If I talk about white color, guys, non-herpetic genital ulcers, and blue as well. And how to differentiate, guys? Patient who are responding to penicillin or allergic to penicillin. Okay, you also have to remember what, guys? Kit 1 number wise. Okay, it's not like you will remember them just gray, green, white. You have to remember sometimes the examiner can play with the options. He can write you kit 2 red, kit 2 blue, kit 2 green. Okay, so you have to remember the number of the kit along with the color. Is that clear? Now each of these kits these are the syndromic color coded kits, my dear students. These are the color coded kits. So how you have to remember them? You have to remember these kits contain a particular medication. So if an examiner can ask a twisted question, guys, what are the medications inside the each kit? So let's remember those medications and let's try to integrate that with a bit pharmacology as well. Okay, okay, if I talk about the first kit, that is a gray color kit, guys. In the gray color kit, which is kit number 1, in kit number 1, guys, remember kit number 1 is for anorectal and urethral discharge, and the medication inside this kit, we have azithromycin, and we have cefixime. We have azithromycin and we have cefixime. Okay, azithromycin is a which class of drug, guys? From the pharmacological point of view, it's a macrolides, and cefixime is a cephalosporin. It's a cephalosporin. Okay, remember guys, a little integration. The side effect of azithromycin from the medicine point of view, the side effect is QT prolongation. It causes QT prolongation. Okay, it causes QT prolongation. We have a lot of drugs causing QT prolongation. Just remember right here, guys, macrolide azithromycin causes QT prolongation. Then number 2, guys, we have a vaginal discharge mainly. We have antifungals that will prescribe in the green kit. What are the 2 antifungals, guys? Fluconazole. We have fluconazole and signidazoles. We have fluconazole or signidazoles. Okay, so antifungals that we use inside the kit green, guys, we have fluconazole and signidazoles. Okay, followed by that, guys, we have a kit 3 which are responding to penicillin. Okay, which are responding to penicillin. So remember that drugs that we have in the white kit, we have azithromycin. The drugs we have in white kit, we have azithromycin and we have penicillin. We have benzathine penicillin. We have azithromycin and we have benzathine penicillin. Okay, guys, we have benzathine penicillin. And remember, guys, this benzathine penicillin is also drug of choice for syphilis. This benzathine penicillin is also drug of choice for syphilis. Then, guys, kit 4, which is blue color. Kit 4, which is blue color. The medications inside the kit 4, we have azithromycin and doxycycline. We have azithromycin and doxycycline. We have azithromycin and doxycycline. If I talk about kit 5, which is herpetic genital ulcers, I've already told you what is the drug inside this kit. We have acyclovir. What is the drug inside that kit? We have acyclovir. And if I talk about yellow color kit, that is kit number 6, which is for the lower abdominal pain, we have 3 antibiotics in that. Remember, guys, cefixime. We have cefixime. We have metronidazole. We have cefixime. We have metronidazole, and we have doxycycline. And we have and we have doxycycline. And we have doxycycline. Okay, now remember, guys, metronidazole is also a drug of choice for 2 conditions. Metronidazole is also drug of choice for 2 conditions. I will write it here. Metronidazole is also drug of choice for trichomoniasis. And bacterial vaginosis. Okay, it's a drug of choice for trichomoniasis and bacterial vaginosis. About the trichomoniasis, let me tell you a bit, guys. We have a strawberry vagina, which is also called as colpites maculatus due to the severe itching and inflammation. And remember, this was a question asked this exam, that both partner is treated as well. Okay, partner is treated as well. In which condition, guys? Trichomoniasis. Partner is treated as well. In bacterial vaginosis, guys, we have a criteria called as Amsel's criteria. We have a criteria called as Amsel's criteria. And what do I mean by this Amsel's criteria, guys? There should be the clue cells positive, clue cells present, whiff test positive. There should be a creamy discharge and frothy discharge, okay, and foul smelling discharge, okay. So this was all about Amsel's criteria and trichomoniasis, okay. Remember, guys, it was a question asked, in which of the following condition partner is treated as well? So you'll remember partner is treated also in trichomoniasis, okay. That was a bit integrated, okay. Then the last one, guys, kit number 7, which is black color. In black color, guys, we have azithromycin and doxycycline. We have azithromycin and doxycycline. We have azithromycin and doxycycline. So it was all about Suraksha Clinic kits and the medications inside the each kit. Is that clear to everyone? Okay. So I've already showed you guys a question how the examiner can ask the question. He will just give you the sign and symptom, okay, and based upon those symptoms you just have to prescribe the treatment. Is that clear? All right. Okay, so let's move to the second part, strategy in the case detection, okay, strategy for the case detection. Okay, so how do you remember these cases, guys? We have 3 things: screening of high risk cases, contact tracing, and cluster tracing, okay. So first of all, you have to screen the high risk cases. Who are the high risk cases, guys? Number 1, sex workers. Now, who are the high risk cases that are more prone to the sexually transmitted disease? The sex workers, or the person who is having a multiple sex partners. Sex workers, IV drug abusers, and transgenders. So these are the people, guys, who are having a high risk, and for those people we have to go for continuous screening so that they cannot transmit the infection to other people, okay. The number 2 is contact tracing, guys. What is the contact tracing, guys? Contact tracing are the close contacts of the high risk patients. Testing of close contacts. Testing of close contacts. So testing of close contacts is important, guys. So for example, if if the husband is HIV positive, we make sure that his wife will also go for screening so that she cannot transmit to infection other people, okay. So contact tracing. And third one is the cluster tracing. That is the testing of all individuals living in the same area. Testing of all the individuals, testing of all the individuals living in the same area. Testing of all the individuals living in the same area. So remember, guys, 3 things you have to remember. That screening of high risk cases, contact tracing, and cluster tracing. Okay, what are the screening for high risk cases? The patient, for example, who are sex workers or IV drug abusers or transgenders, okay. The contact tracing, guys, testing of the close contacts, and the third one is the cluster tracing. That is a strategy for case detection, okay. Now the examiner can ask you the question, easy way how he can ask the question based upon that. See, guys, simple question he will ask: out of which of the following is not done in case detection, okay. So case detection in sexually transmitted diseases is done all except, okay, you go for you go for cluster tracing, you go for contact tracing, you go for screening, and the answer is notification, okay, guys. The answer will be notification. Is that clear? Is that clear? Is that clear to everyone? Okay, perfect. Now let's move to the first infection, guys. HIV. Let's move to the let's move to the first infection, HIV. It's caused by human T lymphotrophic virus. It's caused by human T lymphotrophic virus. It's caused by human T lymphotrophic virus. The incubation period of the AIDS is 10 years. The incubation period is 10 years. And the most common age is 30 to 35 years. The most common age is 30 to 35 years. If we talk about the prevalence of the disease, that is 0.26%. That means new cases. Okay, guys, the prevalence of the disease we have 0.26%. Now, if I talk about the window period, guys, what is the window period? It's a time between the entry of the infection. Let's define, guys. In PSM, these definitions are very important, guys. What is primary case? What is secondary case? What is lead time? What is generation time? What is window period? Okay, so we are going to discuss one by one all these definitions, guys. So what is window period, guys? It's a time between the entry of the infection. It's time between the entry of the infection to the detectable antibody present. Okay, guys, so remember 3 weeks to 3 months, we go for P24. We also go for RT-PCR or NAT in the window period, guys. But if asked the single best, you'll go with Western blot. As the single best, you'll go with the Western blot, and you already know northern blot for RNA, southern blot for DNA. Okay, then followed by, guys, route of transmission, guys. If I talk about sexual, guys, it's the most common. It's most common route of transmission of AIDS, and we have more than 90% of cases of AIDS that are transmitted is because of the sexual transmission. Okay, then parenteral is the least common. If I talk about the blood transfusion, guys, 95%. Okay, if I talk about needle prick, we have 0.33%. If I talk about needle sharing, guys, we have 0.66%. If I talk about mother to child transmission, guys, we have 30%. But on treatment, we have less than 1%. And breastfeeding, my dear students, we have 12 to 16%. Okay, so talking about the route of transmission of AIDS, guys, we have sexual, that's most common, more than 90%. We have parenteral, that is the least common. We have blood transfusion, which is 95%. We have needle prick, 0.33%. We have needle sharing, 0.66%. We have mother to child, 30%. And we have breastfeeding, guys, 12 to 16%. But if the mother to child, they are on the treatment, both of them are on the treatment, guys, then it would be less than 1%. Okay, now what are the clinical features, guys? If we talk about the clinical features in the initial infection, guys, it's asymptomatic, but we have a AIDS related complex that the patient will complaining of the weight loss more than 10%. Patient will have a weight loss more than 10%. Okay, followed by that patient will have a fever. Patient will have a fever for more than 1 month, and patient will have a diarrhea for more than 1 month. Okay, that's AIDS related complex, guys. Patient will complaining of weight loss, fever and diarrhea for more than 1 month. Now the important question that they can ask, guys, remember, guys, now the important question that they can ask is an opportunistic infection. Now the important question that they can ask is opportunistic infection. What do I mean by opportunistic infection, guys? Infections that occurs due to the low immunity, or infections that occurs when the patient is in the immunocompromised state. For example, guys, if we take a simple example of the pregnancy, after the pregnancy in the puerperium period, that is the recovery period, patient is still in the immunocompromised state. So what are the infections that occurs? Patient is mainly having endometritis. Okay, patient will having mastitis, patient will having urinary tract infection. So those are the opportunistic infections that occur in the immunocompromised state. And same is the case here, guys, in this HIV patient. Okay, guys, in this AIDS related patient, guys, he is having a decreased immunity. He's having a decreased immunity, and based upon the CD4 count cells, based upon the CD4 count, the infections will start. So you have to remember what are the infections that can be started. So you have to remember, guys, what are the infections that can be started in a particular CD4 count. So if I talk about more than 500, if I talk about more than 500 CD4 count, guys, the opportunistic infections that can take place is none. The opportunistic infections that can take place, it's none. Okay, if I talk about 500 to 200, guys, remember 500 to 200, what are the opportunistic infections that can take place? Tuberculosis, candidiasis, and Kaposi sarcoma. Okay, tuberculosis, candidiasis, and Kaposi sarcoma. And if I talk about most common opportunistic infection in India, most common opportunistic infection in India, you will go with the tuberculosis. You will go with the tuberculosis. Is that clear? So remember, guys, whenever the CD4 count is between 500 to 200, whenever the CD4 count is between 500 to 200, whenever the CD4 count is between 500 to 200, the opportunistic infections that can take place, it's tuberculosis, candidiasis, and Kaposi sarcoma. And more precisely, you remember that most common opportunistic infections that is associated with the AIDS patient is tuberculosis. Now, if the CD4 count is between 200 to 100, if the CD4 count is between 200 to 100, the first opportunistic infection we have pneumocystic jirovecii pneumonia. Pneumocystic jirovecii pneumonia. Okay, and this is most common in world. Remember, guys, most common opportunistic in world, most common opportunistic infection, most common opportunistic infection that is related to the AIDS positive patient, your answer will be pneumocystic jirovecii pneumonia. Okay, then the second opportunistic infection that takes place when the CD4 count is between 200 to 100, your answer will be cryptococcal meningitis. Your answer will be cryptococcal meningitis. Your answer will be cryptococcal meningitis. Okay, then if the CD4 count is between 100 to 150, if the CD4 count is between 100 to 50, your answer will be toxoplasmosis. Your answer will be toxoplasmosis. Your answer will be toxoplasmosis. And if the CD4 count is less than 50, my dear students, if the CD4 count is less than 50, then your answer will be CMV retinitis. Then your answer will be CMV retinitis or Mycobacterium avium complex. Mycobacterium avium complex. So remember guys, the opportunistic infections at more than 500 we have no opportunistic infection that takes place in the AIDS. Between 500 to 200 we have tuberculosis, candidiasis and Kaposi sarcoma. Between 200 to 100 we have pneumocystic jirovecii pneumonia and cryptococcal meningitis. Between 100 to 50 we have toxoplasmosis, and less than 50 we have CMV retinitis and Mycobacterium avium complex. Okay, we'll discuss each of these infections in a short and concise way that you can solve the questions. Now the malignancies that are associated with the HIV patients. What are the cancers that are associated? Remember guys, number one, Kaposi sarcoma. Number one, you will remember Kaposi sarcoma. Now you already know guys, the patients who are more prone to HIV, the patients who are having risk factors for the cervical cancer are the multiple sexual partners, and the people who are having multiple sexual partners are more prone to the AIDS. So also which cancer guys? Cervical cancer. Cervical cancer, and cervical cancer is caused by HPV 16 and 18. If asked more precisely, you mark HPV 16. Okay, and third one is non-Hodgkin's lymphoma, and third one is non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma, cervical cancer and Kaposi sarcoma Now if I talk about the first infection guys that we have talked about, the CD4 count, that when it's between 200 and 200, what was an opportunistic infections that we have discussed that time guys? Pneumocystic jirovecii pneumonia. So it takes place when the CD4 count is less than 200. It takes place when the CD4 count is less than 200. And on the X-ray guys, on the X-ray there are the classical findings. What are the findings guys? Perihilar opacities. Perihilar opacities. Okay, you have to remember guys, in a question examiner will ask, in a very big clinical question he will mention perihilar opacities, and at that time these perihilar opacities, your answer will go to the pneumocystic jirovecii pneumonia. If there is a bilateral hilar lymphadenopathy, you go with the sarcoidosis. Okay, if there is a unilateral hilar lymphadenopathy, you go with the tuberculosis. If there is a bilateral infiltrates present, you go with the RSV. Okay guys, bronchiolitis. Is that okay? Bronchiolitis caused by the RSV. So these all the important findings, that you are going through guys in the chest X-ray. You have to remember the shortcuts, you have to remember the classical findings. So whenever an examiner will mention perihilar opacities, it should be in your mind that he is talking about, and perihilar opacities along with the AIDS patient. Okay, so he's talking about pneumocystic jirovecii pneumonia. Now the drug that we use for the treatment of this pneumonia, it's cotrimoxazole. The drug that we use for this is called as cotrimoxazole, and the prophylactic drug also is the same, cotrimoxazole. The drug also we have cotrimoxazole, and the stain that we use is called as GMS stain, Gomory methamine silver stain. Gomory methamine silver stain, and this Gomory methamine silver stain is usually used in the fungal infections guys. So remember, the stain that we use is GMS stain, the treatment is cotrimoxazole, and on chest X-ray we have perihilar opacities, and the CD4 count is less than 200. Okay, so simple question the examiner will ask, that the AIDS patient with a CD4 count of this, on X-ray there are perihilar opacities, what can be the possible treatment? Okay, so he will give the list of the drugs, you have to mark cotrimoxazole. Either he will ask that what will be the diagnosis, which type of pneumonia, he can write community acquired pneumonia, he can write direct pneumonia. Okay, so your answer atypical pneumonia, pneumocystic jirovecii pneumonia. So you have to remember guys, less 200 or less than 200, the opportunistic infection that takes place in the AIDS positive patient is pneumocystic jirovecii pneumonia. Okay, now the third one is cerebral toxoplasmosis. So toxoplasmosis, I told you, whenever CD4 count is between 100 and 250. Okay guys, so less than 100. So CD4 count less than 100, your answer will be cerebral toxoplasmosis. Cerebral toxoplasmosis. If we see the MRI of the patient, we have multiple eccentric dots. Okay, on the MRI of the patient, we have multiple eccentric dots. Okay, now one thing guys, don't confuse this multiple eccentric dots with neurocysticercosis. Okay guys, don't confuse this with neurocysticercosis. Okay, so remember guys, these are multiple eccentric dots. There are multiple eccentric dots. And if I talk about the triad of this toxoplasmosis guys, we have a triad. Let me write a triad here, H, C and C. So we have hydrocephalus we have hydrocephalus, we have chorioretinitis, and we have intracranial calcifications. And we have intracranial calcification. So we have hydrocephalus, we have chorioretinitis, and we have intracranial calcifications. Now the patient, when having this hydrocephalus and all these symptoms guys, so all these things, the classical clinical feature will be patient will complaining of seizures. So AIDS positive patient complaining the having a clinical feature of seizures guys. On MRI we have multiple eccentric dots. Your diagnosis will be cerebral toxoplasmosis. Your diagnosis will be cerebral toxoplasmosis. So right on MRI we have a finding called as multiple eccentric dots. Now the treatment guys, what is the treatment that you will give? Remember the treatment guys, write it down, pyrimethamine. The treatment is pyrimethamine. We have pyrimethamine, we have sulfazidine, and we have leucovorin. So guys, cerebral toxoplasmosis patient complaining of the seizures. AIDS positive patient, when the CD4 count is less than 100, your diagnosis is cerebral toxoplasmosis. Remember in ophtha guys, when you remember the toxoplasmosis, there's a classical finding, head light and fog appearance. Head light and fog appearance in toxoplasmosis. From ophtha point of view guys, head light and fog appearance will be mentioned in the question guys. And if this toxoplasmosis occurs in pregnancy, because in torch infections you study the torch infections in the pregnancy guys, T for toxoplasmosis, and in pregnancy the drug will be spiramycin. Okay, so it was all about cerebral toxoplasmosis. Is that clear guys? So remember, from the ophtha point of view, head light and fog appearance. The triad, we have hydrocephalus, we have chorioretinitis, and we have intracranial calcifications. Patient will complaining of the seizures. And on MRI we have multiple eccentric dots, Is that clear? So let's move to the next opportunistic infection. And I've already told you guys, in neurocysticercosis there is a larva inside the egg, like multiple dots are like this in neurocysticercosis. Okay, and that time the drug of choice for neurocysticercosis will be guys, it will be albendazole plus steroids. Okay, neurocysticercosis. Okay, you remember, you might have studied guys, Taenia saginata and Taenia solium, followed from the beef and pork eaters. Neurocysticercosis. Starry sky appearance, we call that. Okay, we call that starry sky appearance. Next part guys, CMV retinitis. So CMV retinitis guys, the CD4 count will be less than 50. And it's caused by cytomegalovirus. Cytomegalovirus. And the treatment is Jan cyclover. And the treatment, the drug that we use to treat the CMV retinitis is Jan cyclover. If we talk about the findings, of the CMV retinitis, guys, remember guys, we have a pizza pie appearance. Okay, we have a pizza pie appearance. We have a pizza pie appearance, and we have a spots called as cotton wool spots. We have a spots called as cotton wool spots. Please don't mix it with the CRAO and CRVO, guys. That is different, guys. Okay, so this pizza pie appearance and cotton wool spots is a classical finding of the CMV retinitis. And July 2023, same question was asked, that you have a AIDS patient, guys, treatment was asked. So remember, not every viral condition your treatment is acyclovir. Okay, so I will show you the question, how the examiner has framed the question. So see, a 44-year-old, why I am discussing these opportunistic infections, guys, they are very important from the medicine point of view, from the PSM point of view, because AIDS is important. Okay, so remember how this question was asked, guys. A 45-year-old patient with a history of HIV positive presents to the OPD with a complaint of blurred vision, floaters in the left eye. On the fundoscopy, guys, it was revealed that he has a cotton wool spots. He has cotton wool spots. Okay, and pizza pie appearance, and the diagnosis of CMV retinitis was made. Okay, so patient having a pizza pie appearance and the cotton wool spots, AIDS positive patient is, and you know that in an AIDS positive patient, if the patient is complaining of blurred vision with the fundoscopic findings of cotton wool spots and pizza pie appearance, your diagnosis is easy to catch, guys, CMV retinitis. And which of the following is the most appropriate treatment for this patient? So the answer was, guys, Jan cyclover. What was the answer, guys? Jan cyclover. Jan cyclover. If I talk about other options, my dear students, herpes condition, herpes zoster conditions, we give mainly acyclovir. Okay, herpes related conditions, we give acyclovir. If I talk about cotrimoxazole, my dear students, it is used in pneumocystic jirovecii pneumonia. It's used in pneumocystic jirovecii pneumonia. If we have a pneumocystic jirovecii pneumonia, the drug of choice, prophylactic drug, or the treatment, the drug that we use is cotrimoxazole. If I talk about this tenofovir, my dear students, it's also used in AIDS patients, yes, as a treatment, and also in hepatitis patients. Okay, AIDS and hepatitis. This tenofovir is a triple drug therapy. We give we give this tenofovir with the entracetabine and dolutegravir. We give 3 drugs post-exposure prophylaxis of AIDS. The 3 drugs are entracetabine, tenofovir, and dolutegravir. Okay, so this was all about CMV retinitis. So it's an opportunistic infection that takes place when the CD4 count is less than 50. Okay, so I hope, guys, similar questions same the clinical questions, same way they can ask the other opportunistic infections, whether that is pneumocystic jirovecii, that is cerebral toxoplasmosis, or that is cryptococcal meningitis. Now the third malignancy, guys, the CD4 count, the Kaposi sarcoma, it occurs when the CD4 count is between 500 to 200. It occurs when the CD4 count is between 500 to 200. It's caused by HHV8. It's caused by HHV8. What is this Kaposi sarcoma, guys? It's a vascular tumor of skin mucous membrane. It's a vascular tumor of skin mucous membrane, and the treatment for this is surgery. And the treatment is surgery and chemotherapy. Surgery and chemotherapy. Okay, so this is the tumor of skin mucous membranes, guys, Kaposi sarcoma. This is Kaposi sarcoma. Okay, and it occurs mainly in the stage 2 of AIDS, and it occurs mainly in stage 2 or 3 of AIDS. It occurs mainly in stage 2 or 3 of AIDS. It occurs mainly in the stage 2 and stage 3 of AIDS. Is that clear? Okay, so let's move to the next opportunistic infection called as cryptococcal meningitis. Okay, so let's have a quick review of the opportunistic infections that we have studied so far, guys, okay. So the first opportunistic infection that we discussed was pneumocystic cerevisiae pneumonia, guys. The CD4 count is less than 200. Okay, the X-ray findings, we have a patient having perihilar opacities. Okay, then I told you a bit extra, guys. If you have a if you have a bilateral hilar lymphadenopathy, you will go with the sarcoidosis. If you have a unilateral hilar lymphadenopathy, you'll go with the tuberculosis. If you have a bilateral infiltrates on the chest X-ray, you will go with the bronchiolitis, which is caused by RSV, and the treatment for that is ribavirin aerosol. Okay, let's not go that much. Just remember the X-ray findings. So these are the particular findings. Okay, and the treatment for the same condition as the prophylaxis drug and the drug of choice is cotrimoxazole. The stain from the microbiological or the pathological point of view, guys, remember the stain that we use is called gummory methamine silver stain, GMS stain. Okay, then the second one was the cerebral toxoplasmosis, where the patient will complaining of the seizures. On MRI, we have a multiple eccentric dots, and I told you don't forget this multiple eccentric dots, or don't confuse this with the neurocystic that is different. Patient will having the other features, but here it's a AIDS related will be cerebral toxoplasmosis. The triad, we have hydrocephalus, we have chorioretinitis, and we have intracranial calcifications. Okay, followed by that, guys, the treatment will be pyrimethamine. It will be sulfazidine or leucovorin. Leucovorin is a folinic acid, not folinic acid, which is also an antidote for the methotrexate toxicity. Okay, if pregnancy, the torch infection in pregnancy, if there is a toxoplasmosis, your drug of choice will be spiramycin. Okay, and in ophtha, guys, what is the classical finding in ophtha point of view if this toxoplasmosis is called as head light and fog appearance? Okay, it's related to toxoplasmosis, it's related to toxoplasma gondii, cats ke related hai. Okay, it's caused by the feces, contaminated excretions with the cats or feces of the cats. Okay, so cats related toxoplasmosis. Okay, so then followed by CMV retinitis, guys. The classical finding, fundoscopic findings of the patient will have pizza pie appearance and the cotton wool spots, and your treatment will be Jan cyclovir, and the CD4 count is less than 50. Then followed by the malignancy that is associated with this HIV positive patients, we have Kaposi sarcoma, which takes place when the CD4 count is between 500 to 200, associated with HHV8, guys. The treatment is surgery. Okay, and this image was asked in the NEET exam, guys, in which stage usually it occurs. Stage 2 and 3 it occurs, and the treatment will be surgery and chemotherapy. Okay, it's a tumor of the skin mucous membranes. Okay, after that, guys, now we'll discuss about cryptococcal meningitis. So write it down, guys. Cryptococcal meningitis occurs when the CD4 count is less than 200. Cryptococcal meningitis occurs when the CD4 count is less than 200. Okay, what is the triad, guys? Fever, headache, and neck rigidity. Okay, patient having fever, headache, and neck rigidity, you diagnose it with the meningitis. And the two signs associated with the meningitis, guys, medicine point of view, we have Brudzinski sign and Kerning sign. What are the two signs we have? We have Brudzinski sign and Kerning sign. Is that clear? So write down the clinical features, guys. Fever, headache, and neck stiffness. We have fever, we have headache, and we have neck rigidity or neck stiffness. Fever, headache, and neck rigidity or neck stiffness. Okay, then the CSF test that we do, the ink we use called India ink. We also use ELISA in these conditions, guys, and the treatment will be L-amphotericin B. Treatment will be L-amphotericin B. Okay, so remember, guys, that you have to remember that what are the findings of the bacterial meningitis from the medicine point of view when you study from medicine meningitis. Remember how to differentiate the viral meningitis, bacterial meningitis, cryptococcal meningitis. Okay, so based upon the glucose levels, TLC levels, okay, cells and all. So remember that the treatment, okay, for viral meningitis, the drug of choice is acyclovir. Okay, so let's discuss only cryptococcal meningitis here. So your drug of choice is L-amphotericin B. So if we add a bit pharma in this, guys, is this L-amphotericin B is also drug of choice for leishmaniasis. It's also drug of choice for leishmaniasis or Kala Azar. which is mainly found in UP, Bihar, and West Bengal. Leishmaniasis, guys. Okay, and it's also drug of choice for rhizopus causing condition, mucormycosis caused by rhizopus bacteria, mucormycosis. Okay, it's also drug of choice for mucormycosis. Is that clear? So now the diagnosis, guys, for the screening of this HIV/AIDS, we go for RT-PCR and NAT. Okay, in India we go for Western blot. Single West. Okay, the ELISA have a sensitivity of more than 99%, guys, but the confirmation globally fast. India, it is Western blot, globally fast RT-PCR NAT, nucleic acid amplification test. Okay, the other test that we do for this HIV, we have HIV viral load. We have HIV viral load. We go to check CD4 percentage. We check CD4 percentage, and my dear students, we check P24 antigen. These are the other tests that we do for HIV/AIDS. The other tests that we do for HIV/AIDS. Then, guys, the treatment. Okay, the treatment. Important part, the treatment, guys. Remember, we have highly active antiviral therapy. Highly active antiviral therapy. We have highly active antiviral therapy. Okay, now the question is, guys, when to start the treatment for the AIDS? What should be the CD4 count and when you start the treatment of AIDS? You can write in the comment section. When to start the treatment of AIDS, guys? You can write in the comment section. Yes, what should be the CD4 count at which we have to start the treatment in the AIDS positive patient? Your options are 500, less than 200, less than 100, or irrespective of the CD4 count, you have to start the treatment in the patient. Irrespective of the CD4 count. So what will be your answer? What will be your answer, guys? When to start the treatment? Yes. You have to start the treatment as soon as possible. Okay, so remember, guys, irrespective of CD4 count. Remember, guys, irrespective of CD4 count, start the treatment as soon as possible. So what are the drugs, guys? We use first line drugs called as tenofovir. The first line drug, we have tenofovir, we have lamivudine, we have lamivudine, and we have dolutegravir. And we have dolutegravir. Okay, we have tenofovir, we have lamivudine, and we have dolutegravir. Okay, the second line drugs that we have, remember, my dear students, the second line drug we have zidovudine. The second line drug we have zidovudine, we have lopinavir, we have lopinavir, we have ritonavir, and we have lamivudine, So zidovudine, ritonavir, and lamivudine are the first line and second line drugs. Now the post-exposure prophylaxis. What is the post-exposure prophylaxis, guys? When to start the treatment, guys? Remember, as soon as possible. Remember, guys, as soon as possible. Number one thing. Number second thing, guys, you have to maximum duration of within 72 hours. maximum duration of within 72 hours. Okay, so duration post exposure prophylaxis, you will start 28 days and then you will do the test after 3 months, ELISA. Okay, so when to start the treatment, guys? As soon as possible, within 72 hours. Duration should be 28 days and tests after 3 months of the exposure, you will go with the ELISA. Now this important, what are the drugs? Remember, guys, what are the drugs that you have to remember? Okay, triple drug therapy we use tenofovir, we use dolutegravir, and we use antacid and we use antacid. Okay, so these are the drugs that we use in the post exposure prophylaxis. We don't start with the one drug, my dear students. Remember, we start how many drugs? We start at least 3 drugs. If we talk about the newborn prophylaxis, if we talk about the newborn prophylaxis, now if the baby is born to the positive HIV mother, what are the prophylactic drugs? When to start, guys? As soon as possible, because we know the route of transmission from the mother to child is less than 1% when on treatment. So what are the drugs we use? Remember, guys, the drugs we use is nevirapine. It's nevirapine, having the 50% efficacy. And the second drug we have zidovudine, and the second drug having zidovudine, having the 66% of efficacy. Okay, and remember, guys, duration minimum up to 6 weeks. This was the question asked in the exam, guys. Minimum duration of the prophylactic drug nevirapine and zidovudine, it's minimum up to 6 weeks. Minimum you have to start it with the 6 weeks, and it can go up till 18 months. And it can go with 18 months. Is that clear? So that was all about the AIDS in newborn prophylaxis treatment. Now if I talk about prevention of child and transmission, guys, nevirapine 50% efficacy, guys. Zidovudine having 66% efficacy. Through cesarean section, guys, prevention by 50%. Cesarean section plus ART 75%. ART mother plus ART baby, guys, we have 90 to 95%. Is that clear? Okay, now the 5 classical STDs, other classical STDs. Just remember that what is a causative agent and what is an incubation period, guys. In micro and patho, you might study them. In dermat as well, guys. In dermat and micro, they will be revised again. But for now, guys, HIV we have studied in a detail. More importantly, the opportunistic infections, guys, we have discussed them from the medicine aspect, from the pharmacological aspect. So we try to cover them from both the sides. Okay, so remember, guys, the other classical diseases we will go through superficially, guys, because they will be again repeated in the other subjects as well. Okay, so syphilis, guys, it's caused by Treponema pallidum. Treponema pallidum, and the incubation period is 9 to 90 days. The incubation period is 9 to 90 days. If I talk about gonorrhea, guys, it's caused by Neisseria gonorrhea. It's caused by Neisseria gonorrhea, and the incubation period is 1 to 5 days. If I talk about chancroid, guys, it's caused by Haemophilus ducrei. It's caused by Haemophilus ducrei, and the incubation period is 3 to 5 days. The incubation period is 3 to 5 days. If I talk about LGV, guys, by Chlamydia trachomatis, the incubation period is 3 to 12 days. Last one is donomatosis, guys. Remember, this donomatosis is caused by C. bacterium granulomatosis. It's caused by C. bacterium granulomatosis, and the incubation period is 3 to 21 days. So syphilis, gonorrhea, chancroid, and LGV, guys, you have to remember, guys. You will study them in the micro and as well as in the dermat as well. Okay, so but for now, guys, it was all about HIV treatment, diagnosis, okay, and the opportunistic infection associated, and the Suraksha clinic. Okay, so let's see that what are the possible questions, guys. So if we'll see this question, guys, a nurse sustained a needle stick injury while sampling blood of a patient who is HIV positive. Which of the following given below is incorrect? Can you answer this, guys, in the comment section? A nurse sustained a needle stick injury while sampling a blood of a patient who is HIV positive. Now, what will be your post-exposure prophylaxis? Out of which of the following is incorrect, guys? Post-exposure prophylaxis. Post-exposure prophylaxis. Yes, everyone. Post-exposure prophylaxis. Yes. Post-exposure prophylaxis. Yes, the answer is administration of tenofovir monotherapy. Administration of tenofovir monotherapy. Yes, we don't use the one drug, guys. I told you we use the 3 drugs: entacetabine, dogletraver, and tenofovir. So out of all these options, guys, which one is the correct? Administration of tenofovir monotherapy. Is that clear? Okay. A nurse got an accidental prick from a needle used for an HIV positive patient. Which single test, if I ask single test, will lead to the confirmatory diagnosis, guys? Western blot assay. Western blot assay is the single best treatment. Okay, then HIV positive prophylaxis should be started ideally within the maximum duration of guys, how many hours? 70 within a maximum duration of 72 hours. Ideally, you have to start it as soon as possible, but with a maximum duration of 72 hours. Okay. A 25-year-old lady coming to the clinic with the complaining of vaginal discharge. With the complaints of vaginal discharge, the color kit used is. Yes, in the comment section you can answer down. What will be the drug that will be used? What will be the kit that will be used, guys? What will be the kit that will be used? The kit that will be used is it's kit 2 green color. Okay guys, the kit 2 green color. If I talk about kit 1 gray, it was for anorectal discharge and urethral discharge. Okay, kit 6 is not green color, kit 6 is yellow color, and yellow is used for PID or lower abdominal pain. Okay, same goes with this one. So you have to remember the kit number along with the color. So that was all about sexually transmitted disease. Now let's start the family planning and contraception. Is that clear to everyone? The chapter number 1 clear to everyone, guys? Yes, write down in the comment section, guys. Is that clear to everyone? Any doubts, any single thing you have to ask? Any single thing you have to ask? Okay, so we can start with the family planning and contraception. So let's discuss this chapter, guys. Family planning and contraception. So we have two types of contraceptions, guys. First one is contraception that is used during the intercourse, and contraception that is used after the intercourse. So write down the first one, guys. Contraception used during the intercourse. During the intercourse. Now the contraception that is used during the intercourse, for example, we have example male condoms, we have female condoms, we have male spermicidal gels, such as non-oxynol 9, and then we have interceptive contraception, guys. What do I mean by interceptive contraception? The contraception that we use after the intercourse. So write it down, guys. Used after the intercourse. So contraception used after the intercourse, that is called as interceptive contraception. Okay, so what are the examples of interceptive contraceptions, guys? For example, all the emergency contraceptions. Emergency contraceptions, your examples will be progesterone only pills, okay, oral contraceptive pills, intrauterine devices, okay, RU486, that is mifepristone and high dose estrogen. So we have two types of contraceptions. First part is the contraception that we use during the intercourse, and the second is contraception that we use after the intercourse. Okay, now let's discuss them one by one. What are the possible side effects, what are the ideal timings and ways to use that. If we talk about progesterone only pills, remember my dear students, they are used within 72 hours. They are used within 72 hours. And one more important part you will remember, guys, they are the contraception of choice in lactation. They are the contraception of choice. They are the contraception of choice in lactation. So guys, in lactation, guys, OCPs are contraindicated. So you remember one thing now, that in lactation period, that OCPs are contraindicated, and at that time what will be your treatment, what will be the contraception of choice? Progesterone only pills, POP. If I talk about combined OCPs, guys, we have a regime called as USP and Lancy regime. We have a USP and Lancy regime, and we have to use combined OCP also within less than 72 hours. Okay, within 72 hours or less than 72 hours. If I talk about IUDs, intrauterine devices, guys, they are used up to 5 days. They are used up to 5 days and they have a highest efficacy. they are used up to 5 days and they have a highest efficacy. Okay, and then we have RU486, that is mifepristone, which is mifepristone and which is used within 72 hours. Used within 72 hours. Okay, and high dose estrogen, guys, used continuously for 5 days. Used continuously for 5 days. So we have types, guys. First of all, I discuss the contraception. We have either contraception that you use during the intercourse or the contraception that you use after the intercourse. Number one thing. Number second, guys, the examples of the contraception that you use during the intercourse, we have male condoms, female condoms, and the male spermicidal gel, non-oxynol 9. And then the interceptive contraception that you use after the intercourse, we have the emergency contraception medications. For example, we have progesterone only pills, we have OCPs, we have intrauterine devices, RU486 mifepristone. Then we have a different ideal timings of these contraceptions that we use. If we talk about POP, guys, we have to use progesterone only pills within 72 hours. If we talk about COCPs, guys, that's USP and Lancy regime within 72 hours. I will discuss this USP and Lancy regime as well. Intrauterine devices, guys, they can be different, first generation, second, third, fourth, and they have a highest efficacy and used up to 5 days. RU486, what do I mean by used up to 5 days? Within 5 days you can insert it and you can prevent the pregnancy, but then they have a lifespan of 10 years, 7 years, 5 years, depending upon the type of the intrauterine device. Okay, and then you have a high dose estrogen that is used continuously for 5 days. That's used continuously for 5 days. Okay, now the couple protection rate. What is CPR, guys? It's a percentage of eligible couple using an contraception. Okay, percentage of eligible couple, percentage of eligible couple using an contraception. Using an contraception. Okay, so how to calculate it, guys? Total protected couples upon total emergency contraceptions multiplied by 100. Okay, you have to remember, guys, CPR is more than 55%. CPR is more than 55%, but question that they can ask, what is the goal of the couple protection rate, guys? The goal is 60%. The goal is 60%. Okay, the goal is 60%. Okay, the current CPR is more than 55. Okay, but the goal of the CPR, you have to remember, guys, 60%. Now to assess this failure of the contraception, guys, to assess the failure of the contraception, we have an index called as Pearl Index. We have an index called as Pearl Index. What do I mean by Pearl Index, guys? It's total accidental pregnancies, total accidental pregnancies upon total months of exposure, upon total months of exposure multiplied by 1200, multiplied by 1200. That will tell us about the contraception failure Pearl Index. That will tell us about the Pearl Index. Then the method of OCPs, guys, you have USP and Lancy method, guys, combined OCPs. Okay, you have a regime called as USP and Lancy regime, guys. You have to give 4 plus 4 medications, guys, within a gap of 8 hours. The gap should be 8 hours between these two medications, and you have to give it within 72 hours, and you have to give within 72 hours. So that is USP and Lancy regime. Okay, so what is USP and Lancy regime, guys? You give the medications 4, then with a gap of 8 hours you again give 4 medications for the combined OCPs. Then the progesterone only pills, guys, you give 2 pills. You give 2 pills with a gap of 12 hours. With a gap of 12 hours, and each pill should be 0.75 mg, and each pill should be 0.75 mg. But now we have a single pill, guys, morning pill or I pill that you call, that is a single pill, guys. If single, 0.75 plus 0.75 is 1.5 mg. Okay, so remember, if they are single pill, guys, that's what unwanted 72 with the trade name 1.5 mg. 1.5 mg. But if two pills, guys, progesterone only pills, levonorgestrel. What is inside the POP pills, guys? It's levonorgestrel. I will writing it down, guys. It's levonorgestrel. Okay, it's a progesterone only pills. If 2 pills, guys, you will give 0.75 mg each, and if 1 pill, guys, it's 1.5 mg each. Okay, then we have a natural methods as well. We have a natural methods as well for the contraception. What are the natural methods that we have, my dear students? We have calendar rhythm method. Okay, based upon the calendar, the female will remember about her cycles, and then followed by that she will get to know what is the safe time, what is the time other than an ovulation. Okay, and basal body temperature, guys, it's said that during the ovulation time, guys, your basal body temperature increases by 0.5 Celsius degrees. Okay, guys, 0.5 or equal to that, it increases. Then the cervical mucus or billing method or ovulation method, based upon the cervical mucus, guys, whether the cervical mucus is thin, thick. Okay, based upon those chains in the cervical mucus, we get to know that whether the patient is in ovulation or not. But all these natural methods have highest chances of failure, Then, guys, abstinence, guys. Okay, don't do intercourse at all, abstinence. That followed by that, guys, coitus interruptus or the withdrawal method. Once the male is about to ejaculate, you have to withdraw it, which can prevent the pregnancy. Okay, and then due to the anovulation in the lactational amenorrhea method. Okay, guys, due to the anovulation, when the ovulation won't happen, guys, and such type of contraception naturally occurring is called as lactational amenorrhea method. Okay, now this cervical mucus, if I tell you a bit, guys, remember, guys, if I'll explain it a bit, we have normally how many days of cycle, guys? We have normally 28 days of cycle. Okay, we have normally how many days of cycle, guys? We have 28 days of cycle. Now in the first 14 days, we call it as which phase? Proliferative phase. Proliferative phase. And after 14 days, we call it as secretory phase. After 14 to 28 days, we call it as secretory phase. So we have proliferative phase and secretory phase. Now what happens in this proliferative phase, my dear students? The endometrium will start to grow. Under the influence of the estrogen. Okay, now the estrogen is coming, estrogen is helping. Okay, estrogen is helping the endometrium to grow in a proliferative phase. And this estrogen is thin, guys. And that's why on the drying we have a ferning pattern. Okay, and now if I talk about the secretory phase, guys, in secretory phase, which is the hormone that will responsible for this making the endometrium juicy, guys, making the secretory endometrium, that is progesterone, and that is the thick secretions will have. Okay, and there will be loss of ferning pattern, and on drying there will be loss of ferning pattern. Now 2 questions can be asked, guys. Now why I mentioned this here, to understand, guys, it will be difficult for a sperm to travel in the thick medium comparatively to thin. So whenever the cervical mucus is thick, that is a good time for the that will act as a contraception. Is that clear? Now if it is thin, that means it's a proliferative phase. Okay, sperm can travel and it can fertilize the ova on the 14th day, because sperm can live up to 72 hours. Is that clear? So now from the gynecological way aspect, that the question they can ask, they can give you the image of the ferning pattern, and the simple question that they will ask is, which of the following hormone is responsible for this pattern? So your answer will be estrogen. Okay, this test is called as spin bucket stretchability test. Okay, spin bucket stretchability test. So did you understand, guys, how the cervical mucus helps acts as a contraception? So remember, whenever there is a thick secretion, guys, thick cervical mucus, that means it's after 14 days ovulation has passed. That's why this is a safe time, and this is a good time which works as a contraception, because it's very difficult for a sperm to travel in the thick medium. Okay, such test is called as spin bucket stretchability test, which is a test of an ovulation. Okay, is that clear? Chalo, guys, then we have a barrier methods as well. The barrier methods, the goal of these barrier methods is to prevent the fertilization. What is the goal of these barrier methods? To prevent fertilization. But the advantage of these barrier methods, is they prevent sexually transmitted diseases. Okay, they prevent sexually transmitted diseases. Okay, and the efficacy of this barrier methods, is increased by spermicidal gel. The efficacy of this barrier methods it is increased by spermicidal gel. Okay, now what is the spermicidal gel that we use? Is non-oxynol 9. It's non-oxynol 9. Is that clear? Okay, so remember, guys, the barrier method, the goal is to prevent the fertilization, and to increase the efficacy of these barrier methods, we add a gel called as male spermicidal gel non-oxynol 9. The examples, we have condoms, we have cervical caps, we have vaginal sponge tablets. Okay, now the image, the condom, female condom with the 2 rings, guys. This is a female condom, this is the male condom, guys. This is called as diaphragm or douche cap. Or douche cap, guys. How to use it, guys? You have to use 4 to 6 hours. You have to insert this vaginal diaphragm or the douche cap 4 to 6 hours prior to intercourse. You have to prior to intercourse, and then take out 4 to 6 hours after the intercourse. Okay, the one of the important question that they can ask, the given image is the vaginal diaphragm or the douche cap. What is the complication associated? Guys? It's toxic shock syndrome. Remember, guys, the complication that is associated with the given contraception, guys, is toxic shock syndrome. Toxic shock syndrome is caused by Staph aureus. Okay, Staph aureus. Okay, so what is the complication of this vaginal diaphragm, guys? Toxic shock syndrome. Okay, and this was the image given in the 2022 June exams. I remember, guys, 2022 June exams, and it was given that in this contraception, what is the medication inside used? Okay, so inside we use non-oxynol 9. It's visible here, guys. Inside this today tablets we have non-oxynol 9. These are called foam foam tablet or vaginal sponge, and it contains, and today contains non-oxynol 9,000 mg. Non-oxynol 9,000 mg. So it was all about, guys, barrier methods, and the classical advantages, they prevent the sexually transmitted diseases. Okay, now intrauterine devices. Okay, so remember, my dear students, we have different types of generations in the intrauterine devices. The first generation, if we talk about the first generation, in the first generation, guys, the examples that we have Lippel's loop, and we have Grafenberg ring, and we have Grafenberg ring, and they are the very old intrauterine devices, guys. And it was said that the mechanism of action of these intrauterine devices, it was not proved, but yes, some books mentions that it is due to the aseptic inflammation. It causes aseptic inflammation, and you know that during the process of inflammation, guys, there will be rolling, additions and all. At the end there is opsonization, phagocytosis by opsonization, and this macrophages, the macrophages will eat these sperms and prevent the fertilization. Okay, it was known to be, it was not confirmed, but it was known to be the mechanism of action of the Lippel's loop, but it's very old, not now used anymore, guys. The second generation guys, the second generation are the intrauterine devices that contains copper. So copper containing intrauterine devices, the examples of copper containing, we have copper T380A, we have copper T380A, we have copper T300, copper T200, and the mechanism of action is they prevent the fertilization. The mechanism of action of this is they prevent fertilization. Then if I talk about the third generation IUCDs, intrauterine devices, third generation, they are the hormonal containing, guys. Okay, they are the hormonal containing IUCDs. What are the hormones? They have levonorgestrel there. Okay, hormonal containing IUDs. They are third generation. Okay, and the example, the classical example of the third generation of intrauterine devices, we have Mirena. The classical example of the third generation intrauterine devices, we have Mirena. Okay, guys, and which contains levonorgestrel. Okay, the mechanism of action, if I talk about the mechanism of action of this third generation intrauterine device, guys, remember they inhibit ovulation. They inhibit ovulation, and they make cervical mucus thick, okay, and they make cervical mucus thick. And the last one, guys, we have a fourth generation. The example of the fourth generation intrauterine device we have is FlexiGuard. Okay, the fourth generation, we have the example called as FlexiGuard, and FlexiGuard also prevents fertilization. Okay, so intrauterine devices, guys, we have four generations. First generation, very old generation, guys, Lippel's loop and Grafenberg ring. Second generation, we have copper T380A and copper T300, guys. They are the copper containing intrauterine devices. The third generation, guys, we have Mirena, which is a hormonal containing intrauterine devices. And the fourth generation, we have FlexiGuard. Okay, guys, and fourth generation, we have a FlexiGuard. Okay, and the mechanism of action is prevents fertilization. If I talk about this, guys, this picture, this is a third generation. This is a third generation intrauterine device, Mirena. Okay, which is a which generation? Which is third generation, containing hormones L and G, and the lifespan of more than 5 years, 5 to 7 years. Okay, if this is the second generation, guys, this is a second generation intrauterine device. Ask question multiple times. Okay, copper T380A, and the lifespan of 10 years, with a lifespan of 10 years. And the last one is, guys, Lippel's loop, and the last one is Lippel's loop. Is the first generation intrauterine device. It's a first generation intrauterine device. Is that clear? So now, guys, what can be the contraindications of these intrauterine devices? What can be the contraindications of these intrauterine devices? Now, the contraindications, you have to remember, guys, either there will be an absolute contraindications that you don't need to use it all, okay, or the relative contraindications where the benefits are more than the risk, So absolute contraindication, first of all, guys, if we talk about an ectopic pregnancy. What is an ectopic pregnancy, guys? Pregnancy outside the uterus. And the most common site of ectopic pregnancy is fallopian tube. If asked most common in fallopian tube, then it's ampulla. Okay, so we'll discuss that in OB-GYN, guys. So here if the patient is having a ectopic pregnancy, if I talk about the causes of ectopic pregnancy, guys, the use of intrauterine devices is also a risk factor for ectopic pregnancy. So the patient having a history of ectopic pregnancy, it's absolute contraindication for IUD. So write it down, guys, history of ectopic pregnancy. History of ectopic pregnancy. History of ectopic pregnancy. If I talk about second, guys, pelvic inflammatory disease. But pelvic inflammatory disease, current. Okay, guys, current PID. Okay, if the patient is having a current PID, absolute contraindications. Okay, third one, if the patient you are having the pregnancy, so suspected pregnancy. Okay, suspected pregnancy. And the last one, guys, if the patient is having undiagnosed bleeding PV. Undiagnosed bleeding PV. What do I mean by undiagnosed bleeding PV, guys? Abnormal uterine bleeding. Okay, any bleeding other than the normal menses is an abnormal uterine bleeding. Okay, so if the patient is having any undiagnosed bleeding per vaginal, guys, these are all the absolute contraindications of intrauterine devices. Okay, now the relative contraindications, guys, where the benefits are more than the risk or where you can use. Okay, absolute don't use at all, relative 50-50. Okay, now the relative contraindications kya rakhoge yaad, guys? History of PID. If the patient is having a history of PID, okay, if the patient had a PID in the past, okay, then the malformation of the uterus. What do I mean by the malformation of the uterus, guys? For example, patient will have a septate uterus, patient will have a bicornuate uterus. Okay, so remember, malformation of the uterus. What's that, guys? Septate or bicornuate. Septate or bicornuate uterus. Or the patient is having the fibroid. Patient is having the fibroid. Now what can this fibroid do, guys? The fibroid, if you know, guys, that can cause the non-uniform enlargement of the uterus. Now the patient is having fibroid, it's growing. It can suppress this intrauterine device, which can perforate inside, and patient will start bleeding. Okay, so that's why during the fibroids it's really contraindicated to use the intrauterine devices. And the side effect of this intrauterine devices, patient can complaining of menorrhagia, that is the more bleeding. Okay, bleeding more than 80 ml. So if the patient is having anemia, so anemic patients are also contraindicated. Anemia is also contraindicated. So write it down, guys, anemia. Okay, so two things I've discussed here. Fibroid, so I've told you fibroid, guys, if the fibroid is growing larger, what will happen to the intrauterine device? It can compress it down and it can perforate inside. Okay, now if it's perforating, it can cause bleeding. Yes or no? So that's why during the fibroids, if the patient is having the fibroid, okay, the IUD is contraindicated. Doesn't matter the site of the fibroid, it can be mural, intramural, submucosal, okay, pedunculated, whatever it is, guys, but it is contraindicated. Okay, in anemia, guys, the side effect of intrauterine devices, we have menorrhagia. What is menorrhagia, guys? Excessive bleeding more than 80 ml. In the normal cycles, how much is the bleeding, guys? It's 30 ml. But if it exceeds 80 ml, we call it as menorrhagia. And if the patient is having, if the patient is anemic, if the HB is already less, now the intrauterine device, if we'll use, it will cause more bleeding. Patient will be more anemic. It will, from moderate, it can go to the severe anemic. That is why in anemia also the intrauterine device is contraindicated. And all the last related contraindication, we have a history of multiple partners. Patient with a history of multiple partners. Patient with a history of multiple partners. Okay, then the side effects of intrauterine copper devices. And the side effects of intrauterine copper devices, I've told you already, guys. The first side effect is menstrual irregularity. The most common, we have menorrhagia. We have menorrhagia, and patient can have polymenorrhea. And patient can have polymenorrhea. What do I mean by menorrhagia and polymenorrhea, guys? Menorrhagia when the bleeding exceeds more than 80 ml, and polymenorrhea when the bleeding when the cycle occurs less than 21 days. Okay, and at that time, if what will be the management, guys? Management is reassurance. Okay, remember guys, management is, no need to write it, management is reassurance for this menorrhagia and polymenorrhea, and prescribe patient of folic acid. Okay, now if there is a pain, okay, and pain will be due to the infection. Okay, now pain will be due to the infection. Okay, and if the patient having pain and infection altogether guys, your treatment will be remove the IUCD. So remove the intrauterine copper device and start antibiotics. And you have to start antibiotics, and you have to start antibiotics. Is that clear? So that is the management of the pain infection. If there is a failure of the intrauterine copper device, what do I mean by failure guys? Pregnancy with intrauterine copper device. So pregnancy with IUCD in situ. In situ means inside. Okay, so if there is a pregnancy inside, if there is a pregnancy and still after using the intrauterine copper device, first of all guys, management, what is the management guys? Remove the thread, remove intrauterine copper device. Okay, now once you remove the intrauterine copper device, remove the thread. Okay, if you're not able to locate guys, you will go for the investigations, you will go for the abdominal x-ray, you'll go for the CT, you can go for the hysteroscopy. Okay, so after removing that after removing that, it is was the question asked guys, if if in the uterus, if inside the uterus, okay, if in uterus, you will remove with hysteroscopy, and if outside the uterus, you will go with the laparoscopy. Is that clear? So inside the uterus you will go with the inside the uterus you will go with the hysteroscopy, and outside the uterus you'll go with the laparoscopy. But first, after that guys, if the mother wants to continue the pregnancy, you have to tell the abortion percentage is more than 50%, advise her all the terms and conditions, and if she don't want to keep the baby guys, you go for the medical termination of pregnancy, MTP. Okay, by using the two drugs guys, mifepristone and misoprostol, which will kill the fetus, and the other drug misoprostol, which will expel the fetus out. Is that clear? So if there is a failure of IUCD guys, what is the first thing guys? Remove the IUCD. Okay, if you are not able to locate, go for the investigations, and then ask the mother guys if she want to continue the pregnancy, advise her the risk or abortion. If she doesn't want to continue the pregnancy, you go with the medical termination of pregnancy. Okay, and if you are able to locate the IUCD inside the uterus, you remove with the hysteroscopy. If outside the uterus, you go with the laparoscopy. Okay, and if there is a and due to this infection guys, the side effect, it can also cause ectopic pregnancy, that is due to the infection. And due to the perforation guys, it can cause due to the displacement. Okay, if the IUCD is displaced, it can perforate inside and it can cause bleeding, and patient can have anemia due to the heavy bleeding, because it causes menorrhagia and polymenorrhea. When the patient will bleed after every 21 days, eventually what will happen? Patient will have anemia. So it was all about guys intrauterine copper devices, their contraindications and side effects. Is that clear? Guys? Yes, is that clear? Anyone in the comment section? Good. Okay, now guys, oral hormonal methods. Now we have oral hormonal methods. Okay, oral hormonal methods guys, we have medications containing both estrogen plus progesterone, So such type of medication, number one, we have Mala N and Mala D. So what are the medications we have guys? Mala N and Mala D. So what is inside the Mala N and Mala D guys? Remember estrogen, we have ethinyl estradiol. We have ethinyl estradiol 30 micrograms, plus we have levonorgestrel 1500 micrograms. Okay, and you have to give these 21 pills plus 7 iron tablets. Okay, so what is mala N and mala D, guys? They are levonorgestrel and ethinyl estradiol tablets, guys. Mala N and mala D, and they contain 30 micrograms of estrogen, ethinyl estradiol, and they contain 1500 micrograms of levonorgestrel, that is progesterone. Mala N and mala D. Okay, they have 21 pills. Okay, and plus there are 7 iron pills. Pills. And the mechanism of action of this mala N and mala D is, guys, they inhibit the ovulation. So ovulation inhibition. So what is the mechanism of action, guys? Ovulation inhibition. Okay, now, guys, OCPs can increase the cancer and they can decrease some cancers. So what are the cancers OCPs can increase? Remember it, guys. Cancers that can increase with OCP usage. The cancer number 1, guys, remember, breast cancer. So patient with breast cancer, guys, it's totally contraindicated to use oral contraceptives. Okay, it can increase the chance of cervical cancer. It causes hepatic adenoma or hepatic hemangioma. So OCPs increase the risk of which cancer? OCP increase the risk of which cancer, guys? It increase the risk of breast cancer, it increase the risk of cervical cancer, and it increase the risk of hepatic adenoma or hepatic hemangioma. If I talk about OCPs decrease which cancer, my dear students, number 1 is endometrial cancer. Number 1 is endometrial cancer. Number 2, ovarian cancer. Number 3, uterine cancer. Okay, endometrial cancer, ovarian cancer, and uterine cancer. Now in exams it was asked multiple times, guys, which drug increases the risk of endometrial cancer. I'm writing it as an extra point, guys. Which drug increases the risk of endometrial cancer, guys? Endometrial cancer increase risk, okay, with the drug called tamoxifen. This tamoxifen is a class of the drug called as selective estrogen receptor modulator. Okay, this tamoxifen, it causes endometrial hyperplasia, guys, which is a risk factor to the endometrial cancer. Okay, so rather than using tamoxifen, we can use a drug called raloxifene. Okay, we can use a drug called raloxifene, which doesn't have a side effect of endometrial hyperplasia, and this raloxifene is also used to treat osteoporosis. Okay, so remember, this is an extra point, guys. Remember that endometrial cancer, which drug increases the risk of endometrial cancer? Tamoxifen. And tamoxifen is a which class of drug, guys? Tamoxifen is a which class of drug? It is a selective estrogen receptor modulator. It's a selective estrogen receptor modulator. Okay, now the non-contraceptive benefits. If I talk about the non-contraceptive benefits of these OCPs, guys, we use these OCPs in the other conditions. For example, we use these OCPs in the polycystic ovarian disease. We use these OCPs in treatment of acne as well. We use in treatment of fibroadenoma as well. We use them in treatment of abnormal uterine bleeding as well. We use them in the treatment of hirsutism as well. So these are the non-contraceptive benefits of the OCPs. Is that okay? Now what can be the contraindications? Again, guys, we'll have absolute contraindications. We will have first absolute contraindications, and then we have relative contraindications, If we talk about absolute contraindications, guys, patient with a history of breast cancer. I've already told you, guys, if the patient is having the history of breast cancer, or OCPs increase which cancer? Breast cancer. So any patient having the history of breast cancer, the OCPs are contraindicated. Or patient with liver diseases, as it causes hepatic adenoma and hepatic hemangioma. That's why any patient with the liver disease, OCPs are absolutely contraindicated. Any patient with a deep venous thrombosis or cardiovascular diseases, the absolute contraindication for the OCPs. Okay, if I talk about relative contraindication, my dear students, you already know that the contraception of choice for the lactation is progesterone only pills. So that means relative contraindication for OCPs. Which drugs are contraindicated? OCPs. So remember guys, in lactation they are relatively contraindicated. Patient with having diabetes, hypertension and migraine, OCPs are contraindicated. OCPs are contraindicated. Is that clear? So relative contraindications and absolute contraindications of OCPs. Okay, then we have other drugs guys, deport for other contraceptions called as Saheli guys. And in the Saheli guys, we have again a drug SERM. Okay, which drug guys? Ormelofexine. Okay, this ormelofexine is inside the Saheli guys. What is SERM guys? Remember, selective estrogen receptor modulator. We have a one class of drug guys called SPRM, selective progesterone receptor modulator. The example is ulipristol. And this ulipristol guys, it can be used up to 120 hours of unprotected intercourse. Okay guys, SPRM. Okay, that is a SPRM, selective progesterone receptor modulator guys. It is an ulipristol and it can be used up to 120 hours. Okay, it can be used up to 120 hours with a 30 micrograms or 30 mg of dosage. Need to confirm that. Just remember SPRM, ulipristol. The new name of this Saheli guys, we have Chaya. Okay, centroman tablets. Okay, and they have very high failure rate. They have very high failure rate. Okay, then guys, we have a depot formulations guys, injectable hormonal progesterones that can be used. We have two types. We have depot medroxyprogesterone acetate and we have non-ethesterone enanthate. If I talk about the first one guys, depot medroxyprogesterone acetate. If I talk about the first one, depot medroxyprogesterone acetate. Okay, this DMPA guys, it is used, the new name is Antara. Okay, so they can give you this image and tell you which of the following medication is used inside this drug guys. It is, what is used guys? DMPA. This DMPA is also used in case of endometriosis guys, when to decrease the atrophy, to decrease the size of the endometrium, or to go for the atrophy of the endometrium, we use the drug called as depot medroxyprogesterone acetate. The dosage is there and dosage here is absolutely same guys. Remember the dosage guys, 150 mg every 3 months. Remember the dosage guys, 150 mg every 3 months. 150 mg every 3 months. Number one, the side effect of this Antara, we have irregular cycles. The side effect we have is irregular cycles, and it's also used in case of endometriosis guys. Remember that it's also used in case of endometriosis for the faster atrophy of the endometrium. But more faster atrophy that the drug we use in endometriosis is danazol. But that has a side effect of virilization. What is virilization guys? It's breast atrophy, clitomegaly and hoarseness of voice. And once the patient is complaining of the hoarseness of voice, you have to stop the drug. That is endometriosis. Okay, but remember guys, the indication of DMP is also in the endometriosis for the atrophy of the endometrium, where the dosage is also same. So 150 mg every 3 months, depot medroxyprogesterone acetate. We also use this medroxyprogesterone acetate for the abnormal uterine bleeding as well. Okay, then the next one we have netin guys. It's non-testosterone enanthate. It's non-testosterone enanthate. It's non-testosterone enanthate, and this non-testosterone enanthate we have to use 200 mg every 2 months. We use 200 mg every 2 months. 200 mg every 2 months. Okay, then we have subdermal implants as well that we use as a contraception guys. Subdermal implants, we have Norplant containing 6 elastic capsules guys, and each capsule contains the hormone 35 mg levonorgestrel. So what we do guys, we put these dermal implants under the skin via the surgical procedures, and they can have a half-life of they can have a shelf life of up to 5 years. Okay, we have different Norplants guys. You remember the different Norplants? We have Norplant 6, we have Norplant 6, let me mention it that we have Norplant 6 containing 6 rods with a lifespan of 5 years. Okay, we have Norplant 2 as well. Let me write it fully guys. We have Norplant 2 as well containing 2 rods, okay, for 3 years. And we have Implanon or the Nexplanon. We have Implanon or the Nexplanon, which is most accepted, and guys, it contains the single rod and it contains the single rod. Okay, so it was all about subdermal implants. Okay, then the last one guys, we have a permanent surgical methods. Okay, we have a permanent methods or the surgical methods. We can go for the tubectomy or vasectomy. We can go for the tubectomy or vasectomy. So what is tubectomy guys? Fallopian tubes are cutted and ligated. Fallopian tube are and ligated. Okay, most common procedure we use is Pomeroy's procedure. Pomeroy's procedure. Okay, if the question was asked most method of contraception used in India is permanent methods, most common method usually, then the best one they go for the surgical methods. Yes, the vasectomy guys, vas deferens is cut and ligated. Vas deferens is cut and ligated. Okay, if I talk about the most common cause of failure, the most common cause of failure is the misidentification of the vas. The most common cause of failure of the vasectomy is misidentification of the vas. Okay, now one question was asked in the exam that what is the advice you will give the patient after the vasectomy. So remember that guys, the advice that you give the patient after the vasectomy. Okay, advice: use barrier methods for 3 months. Use barrier methods for 3 months. Is that clear? Okay, and as per ESIC Act guys, how many days the leave for the tubectomy guys? 14 days leave. Yes, the question, how many days for vasectomy? 7 days. ESIC Act I have discussed in the high discussion of the PSM. You can check out that video as well guys. As per the ESIC Act, the enhanced leaves that we give For tubectomy is 14 days, and for vasectomy it is 7 days. So it was all about family planning and contraception. Is that clear to everyone? Yes, clear to everyone? Yes. Okay, so let's give a quick review of the chapter, guys, whatever we studied. Okay, then okay, so we started with the family planning of the contraception, guys. I've discussed that there are two types. Either we have conventional that we use during the intercourse, and we have contraceptive that we use after the intercourse. Okay, during the intercourse we have female condoms, male condoms, and male spermicidal gels. And after the intercourse, the contraceptions that we use, we have progesterone only pills, OCPs, and intrauterine devices. Then guys, CPR, the goal is 60%, guys. To assess this contraceptive failure, we have an index called as Pearl's index. The regime that we use for combined OCP is called as USP and Lancy regime. We have to give 4+4 tablets with a gap of 12 hours within 72 hours. The natural methods, guys, we have, but they have a highest chances of the failure. I've discussed a bit, guys, about the spin bucket stretchability test, guys. Whenever the mucus is thick, it's a safe time for the it acts as a contraception. And if it's thin and on drying, it gives a ferning pattern, it's unsafe time. Then the barrier methods, guys, they prevent the fertilization. And to increase the efficacy of these barrier methods, we use the spermicidal gel as well. And the complication that is associated with the douche cap is toxic shock syndrome. Remember that. Today contains the non-oxynol 9. Copper containing intrauterine devices are second generations. Hormonal ones are the third generation. The lifespan of the copper T380 is 10 years, and the Mirena, it is 5 to 7 years. The absolute and the relative contraindications I have discussed, guys. If the patient is suspecting pregnancy or the history of ectopic pregnancy or the current PID, you go with the absolute contraindications. Relative, you go with the malformation of the uterus, fibroid, anemia, and the history of multiple partners. I have discussed what are these explain these contraindications. Remember the guys, pregnancy in situ, they can ask the clinical question. If inside the uterus you mark hysteroscopy, they will give the clinical case, guys. It's a concisely I have taught you guys, but everything is important. Okay, big clinical case they will give, and at the end they will write that IUCD was found inside the uterus. Your mode of removal will be hysteroscopy, guys. Outside the uterus, you go with the laparoscopy. Then OCP increases which cancer, guys? Breast cancer, cervical cancer, and hepatic adenoma. And it decreases which cancer? Endometrial cancer, ovarian cancer, and uterine cancer. Okay, we have a depot formulations as well, guys. DMPA, which contains which is a also used in endometriosis with the side effect of irregular cycles, and the dosage is 150 mg every 3 months. We have non-testosterone enanthate 200 mg every 2 months. We use also subdermal implants containing levonorgestrel 35 mg. The best one is Implanon, and the permanent methods. Okay, so it was all about the family planning and contraception and the sexually transmitted disease HIV, guys. Okay, so level of prevention we'll do in the next lecture, guys. So I hope it was good enough, you guys have an understanding, and in case if you have any doubt, you guys can ping me on the Telegram, guys. Okay, and keep solving the questions, and I hope this session was interactive enough and it will help you to clear your exam as well. Okay, good luck, guys. Keep studying. If you have any doubts, you guys can ping me the doubts only in the Telegram. Okay, only doubts. Good luck. Thank you. God bless you.